Hi, everyone. Welcome to the 2020 Lehigh Valley Epilepsy Education Exchange. Thank you all so much for being with us tonight. My name is Missy Dalloway, and I'm the president and CEO of the Epilepsy Foundation, Eastern Pennsylvania. Now, while we are disappointed that we can't be together in person this evening, we're so glad that we are able to come together over the webinar. We have some wonderful experts with us on the call tonight. Sorry about that, I forgot I'm sharing my screen. We have some wonderful experts with us on the webinar tonight. We're so excited to learn together. Before we get started, I just wanted to, I'm sorry, I'm not able, there we go. So before we get started, your audio and video will be muted throughout. You'll have the opportunity to ask questions via the chat box below. Don't worry about asking questions during the presentation because we'll review them and we will hold questions till the end. And if we have time, the presenter will review them at the end of their presentation. I wanted to offer a special thanks to our conference series sponsors, Greenwich Biosciences, AZI, UCB, and Synovian, as well as our vendor sponsors, SK Life Science, Supernus Pharmaceuticals, and our community partners that I'm sure you know well, Lehigh Valley Health Network and St. Luke's Center for Neurosciences. Our conference series sponsors and our vendor sponsors, they are the reason why we are able to offer our educational conferences, our community events. We are so grateful for their support, and please keep an eye out because following this webinar, we will be sending out a detailed information on our sponsors so that you can get to know them a little bit more since you're not able to meet them in person this evening.
Missy?
Yes.
It's Ellen. It's Ellen. Maybe my screen's wrong, but I don't see how your slides are advancing. Does anyone?
I don't see it either. It's Rena.
Do you see it now?
Yes.
Sorry about that. Let me just go back here.
No
Here's
problem.
our conference series sponsors again, and our vendor sponsors and our community partners. And I would just like to ask for your patience as this is all a bit of a learning curve for all of us. So moving right along, oops, not that far along. Epilepsy, you are not alone. For whatever reason, epilepsy is so frequently regarded as this rare disorder, but the reality of the situation is this is something that affects 1 in 26 people. There's an estimated 3.4 million people living in the United States with epilepsy and 110,000 people right here in Eastern Pennsylvania. So, despite this being a disorder that is rarely talked about, it's really much more commonly occurring than people realize. And we think the best way to have this disorder get the understanding and recognition it really deserves is to talk about it, to spread education, to share our stories, and to really spread the education and train others in seizure recognition and first aid. So we're really grateful that you're here tonight so that we can continue to educate and really broaden our knowledge together. The Epilepsy Foundation Eastern Pennsylvania, we are here for you, just as we have been for the last 45 years. We serve the 18 counties of Eastern Pennsylvania, and our mission is to stop seizures and SUDEP, which is sudden unexpected death in epilepsy, find a cure and overcome the challenges created by epilepsy through efforts including education, advocacy, and research to accelerate ideas into therapies. Now, we are here for you in that we provide support services, resources, programs, community events, and the vast majority of these programs and services are completely free of charge. We are here to serve and support you. Now, how we do that is through a very wide range of programs and services. We offer Project School Alert. Our resource coordinators are out in the community, going to schools, leading seizure recognition and first aid trainings in the classrooms with school personnel, teachers, students, school nurses. They're also doing seizure recognition and first aid trainings with first responders, law enforcement, local businesses. Whoever is open to it, we will come in and lead these trainings. We are really trying to spread that education to really help, to help so that the public knows how to react and respond in the situation of someone having a seizure. We offer monthly support group meetings all across our region, advocacy efforts on the state and federal level. We offer educational conferences like this one tonight, as well as across our region. We do retreat programs such as Camp Achieve, which is a week-long sleepaway camp for children ages 8 to 17 with a primary diagnosis of epilepsy, as well as our young adult retreat every May, and our brand new adult wellness weekend, which will be in September. Now, how can you be involved? Well, you can participate in any of those programs and services I previously mentioned. You can do your part to raise awareness, wear purple, do some sidewalk chalk art in your driveway while you're home, put some banners and signs in your yard. You can advocate for epilepsy support services. Follow us on social media. We're at EFEPA on all social media platforms. Volunteer with us, fundraise for us, attend our programs and events. And speaking of, one of our very favorite is our Walk to End Epilepsy. Now, with everything going on, I'll say, unfortunately, we have to host it virtually, but we're actually really excited with the program that we've come up with. So we were supposed to be having 2 walks this June, our Walk to End Epilepsy in the Lehigh Valley on June 14th, and our Walk to End Epilepsy in Philadelphia on June 20th. We are taking both of those walks virtual in kind of a week-long virtual walk effort where we will be hosting a virtual walk ceremony on Sunday, June 14th at 11 a.m. And then you'll be encouraged to walk that week. We're challenging our community members to do a fun 1-mile walk or the 5K challenge, which is 3.1 miles. You don't have to do it in one shot. You can break it up as the week goes on, but track your steps with an app or a pedometer. And then we will be hosting a virtual closing ceremony on Zoom Saturday, June 20th at 11 a.m. And just as always, if you raise $35, you will get your participant t-shirt, but this year it'll just be mailed to you. So we're really excited about it. We're excited to see the pictures and videos of our community members walking in their neighborhoods and community parks and sharing on social media. And there's going to be lots of challenges and prizes and incentives all through the week. So definitely tune in. If you haven't yet, please register today at epilepsywalklv.org. We're really excited and think it's going to be a great time. But really, really happy to have all of you join us tonight. Excited for the program that we have ahead of us. Excited to learn together. And without further ado, I would love to introduce our Lehigh Valley Resource Coordinator that I'm sure many of you know and love very much, Ellen Baca.
Thanks, Missy. Good evening, everybody. Let me just share my screen here that we can continue. As Missy said, do we see that? Is it being shared?
We see your, yep, we see your slide, Ellen.
Okay, great. So yes, so besides all the things that I hope, first off, I hope that everyone's doing well and staying safe. I'm sorry that I can't see a lot of you, but hopefully we'll be together again soon. Besides this conference this evening, we also have a conference coming up on May 26th, which is less than 2 weeks away. And the topics are about SUDEP, knowledge is power, and the emerging treatments for drug-resistant epilepsy. There are great speakers, and we're really we're excited about that. It works the same way as this one does, where you need to visit, in this case, the website is epilepsyeducationpa.org to register, and then closer to the date, you will get a link to the webinar after you register. So there's that coming up. And during this time, we've been doing a lot of virtual webinars and virtual learning opportunities. So the Epilepsy Foundation, we provide seizure recognition and first aid on a continuing basis. These are just a few of the ones that are coming up. We add them all the time, depending, you just have to give us a call and we'll set up a training at your convenience whenever it works for you. But right now we've got a few coming up. We've got one for training for teachers and school personnel on May 18th. We have epilepsy at school for nurses on May 19th, and seizure recognition in adults and children, and that's more a generalized training. The epilepsies at school program, the teachers and nurses can get Act 48 and Act 58 credits. So, but we also train, we go out to, we do any kind of education in the workplace. We provide training for first responders and law enforcement. And they also they receive continuing education for that. So many of them are continuing ed. They're all free, and we're happy to do it for you anytime. So there's that. This is the conference schedule for this evening. We're just about 5 minutes over. I'm going to be wrapping up in a second, and then we're going to start with, we have 3 wonderful speakers this evening, and we're going to be starting with Shannon Kelley, and she's going to be talking about neuropsychological testing. And without further ado, I would like to introduce Shannon Kelley. She's a neuropsychologist who joined Lehigh Valley Network in 2017. At Lehigh Valley Health Network, she conducts neurophysiological evaluations with adults referred primarily from neurology and neurosurgery. She earned her bachelor's degree in psychology from Monmouth University and her master's and doctoral degrees from Chestnut Hill College in Philadelphia. She completed her pre-doctoral internship at Franciscan Children's Hospital in Boston, Massachusetts, and her 2-year neuropsychology postdoctoral fellowship in the Department of Neurology at the Hospital of the University of Pennsylvania. In her free time, she enjoys spending time with her family. So without further ado, Shannon will get you started. And I will take off my PowerPoint here.
Good evening, everyone. Can you see me?
Yes.
Okay, I'm just trying to work on sharing my screen here. Not sure if that is working.
We can see your screen and there it is, perfect.
Okay, do you also see, is this an okay view? Do you see the panel on the side here?
We just see the exact slide you're on, so you're good.
Okay, wonderful, wonderful. Well, thank you so much for having me here. I am very excited to be speaking with everyone this evening. And so tonight I will be talking about neuropsychological evaluations, what they are, and the benefits of being evaluated. So I have nothing to disclose. Although I will say that while I am affiliated with Lehigh Valley Health Network, I just want to mention that everything I talk with you this evening, these are my own opinions and my own views. So the purpose of my talk tonight is to help answer the following questions. So the first question is, what is neuropsychology? What do these evaluations entail? What's involved in evaluation? What do the results tell us? And what is the role in neuropsychology in the treatment of epilepsy? As I'm sure many of us are very interested in the last point. So just to give you an overview of what is neuropsychology, what neuropsychologists are, neuropsychologists, according to the National Academy of Neuropsychology, are professionals within the field of psychology who have special training and expertise in the applied science of brain-behavior relationships. Additionally, the American Academy of Neuropsychology defines neuropsychologists as an independent, professional, doctoral-level psychologist who provides assessment and intervention services based on the scientific concepts of clinical psychology. So what does all of that mean? Basically, neuropsychologists are psychologists by training. As you heard Ellen mention, we complete doctoral degrees in psychology. which includes basic core psychology courses in addition to training in neurosciences, intervention, assessment, and a variety of different areas. And additionally, a completion of a postdoctoral fellowship where we specialize in brain-behavior relationships. So what do neuropsychologists do? Neuropsychologists participate in a variety of different professional activities, and some of them are listed here. So they do assessment, which we're going to talk a lot more about this evening. Different types of intervention. Some do psychotherapy or different therapy services, cognitive rehab. We consult all the time with patients, family members, treating providers, agencies, whoever it may be to help our patients. Also, neuropsychologists play a big role in rehab, whether it be post-stroke, post-traumatic brain injury, whatever it may be on an inpatient and an outpatient basis. Neuropsychologists also participate in independent medical evaluations, or IMEs, which is more for legal purposes. They conduct forensic evaluations, participate in research or clinical trials, and also have quite a presence in teaching and supervision. So what are neuropsychological evaluations? They are the use of objective neuropsych tests, systematic behavioral observations, and interpretations of these findings based on the knowledge of brain-related conditions. So again, what does all of this mean? All these big words. Basically, neuropsychologists use standardized tests and observations to be able to help patients and their treating providers and their family members get a better sense as to what's going on from a cognitive perspective. And so there's a variety of different reasons, different purposes that prompt a neuropsych eval. So sometimes people have evaluations to help lead to a diagnosis or to define brain-related strengths and weaknesses, because we all have those, or to just better determine someone's cognitive profile. Also, we do evaluations to help determine appropriate patient care and planning, treatment planning and remediation, treatment evaluation to document any changes in functioning as throughout the course of someone's treatment. Neuropsych evals are also done for the purpose of research or clinical trials, and also for forensic purposes. So neuropsych tests, neuropsych evaluations, we use a battery approach. And what that means is we use a number of different tests, a variety of different tests to assess different cognitive domains. And so we're going to talk about the domains in a moment, but I think it's important to know that the tests that we use are very specific to the patient that we're seeing. So it's very rare that we use one set of tests for everyone that we're seeing. So here you can see a list of the different cognitive domains that are covered in a neuropsych eval. So as I mentioned, these evaluations are tailored to the particular patient and to the individual and why they're coming for the evaluation. But in general, in order for us to really be able to provide a blueprint as to how someone's brain's working, we like to look at all of these areas. So in terms of intelligence, some neuropsychologists and some evaluations may include a full measure of someone's IQ. In other instances, we may use a more abbreviated measure to be able to help us understand how someone's functioning from an intellectual standpoint. So we use basic measure of intelligence to help us project or anticipate where we'd expect the rest of someone's scores to fall. So if someone's always performing in the low average range, we wouldn't expect all of their other scores to be in the high average range, or vice versa. So it gives us some information that we can use to help predict scores. Additionally, we want to know about someone's academic functioning. So in this area, we may ask you to read some words. We may ask you to do some spelling tests. This part of the evaluation seems the most like school. We also are interested in someone's attention, how well someone can focus on a particular task, aspects of working memory, how well you can hold information for a short period of time, and memory, both verbal and visual memory. So memory is a huge domain. For many neuropsychologists, memory loss, memory difficulties is a really common complaint that we hear. So we are interested in understanding not only how someone's verbal memory is working, but also how their visual memory is working. And memory is really complex. A lot of times people just say, oh, I can't remember something. But for us, we're thinking about so many other layers of memory. So we want to know how well someone encodes or processes and stores information, in addition to how well can they retrieve it or get it back out. So it may be a difficulty in any of the different stages of memory that may in turn lead us to having some difficulties on a day-to-day basis. So we're also interested in looking at language skills. And in this domain, we may ask you to look at some pictures of some objects. We may ask you to name some objects, tell us the definition of some different things. We're interested in visual spatial skills, which generally live more in this right posterior parietal lobe of our brain. And that tells us how well we can judge where things are in space. We're interested in looking at processing speed, motor functions, and the big one, executive functions, which is this, this big term that we use to describe a variety of different functions, including planning, organization, our ability to multitask or shift from one task to another. And we're also incredibly interested in psychologists about the importance or someone's mood, someone's affect, and how that's impacting their ability to think or function on a day-to-day basis. And with all evaluations, we also include measures of effort and motivation, just to make sure, individuals are engaging in the test appropriately. So these evaluations can be quite long, and there are many, many different parts of the evaluations. And so the first part is the interview. There's also the testing portion, which is the piece that patients most often think of, the scoring component, the interpretation, report writing, and the feedback. So these evaluations, like I said, can be very long. And for that reason, we often recommend that prior to an evaluation, people get a good night's rest, they eat a nutritious breakfast, bring any hearing aids, glasses, whatever it is that they need to make themselves most comfortable during the evaluation. And so, at least in my practice, prior to meeting with a patient, I like to review any relevant records. And at that time, it's really helpful for me to have an understanding as to, what imaging has been done, what procedures have been done, what is the epileptologist saying about their current presentation. And then we meet with the individual support person, family member, caregiver, whoever it may be, to gather more information about why they think they're having the evaluation, and importantly, what they're noticing. So we're considering the primary symptoms, and those include events that led to the referral. So why are we having this evaluation? The duration of the presenting problems or conditions. So how long have these things been going on? We're also interested in knowing about any changes. So have these difficulties remained the same for 5 years, 5 months, 5 days? And how have they changed or not over time? And importantly, we want to know about the effects of anyone's difficulties on their day-to-day functioning. So we're also interested in gathering a lot of information on history. So we take it as far back as we can. We're interested in knowing about prenatal history, birth and developmental background, educational history, work history, current and past medical and psychiatric history, any substance use and medications, family history, hobbies, interests, and we also want to know about your personal strengths. So the testing part of the evaluation can last several hours. They range anywhere from 2 to 6 hours. I'd say on average, most patients are with us for 3 to 4 hours of testing. And all of our tests are standardized, which means that they are given to all patients in the same manner, time after time. I think that for many patients, the testing session can feel very intimidating. So I like the patients to know that there's no way to fail the evaluation. Instead, the purpose of the evaluation is to be able to provide the epileptologist, the patient, their family members, more information about what's going on, and to be able to provide a blueprint. So it's also important to know that the neuropsychologist may not be able to provide immediate feedback to the patient in the moment. So we all want to know how we're doing as we're working through tests, but oftentimes the neuropsychologist is not able to provide that immediate feedback. And the tests are difficult. Some are easy. No one is expected to get all of the answers correct. And so we want the patients to know that up front. And all the tests that we use meet standards for psychometric adequacy, meaning that they are reliable. We would get a similar score time after time, given the fact that if nothing has changed. The tests are also valid, meaning that they're testing what we want them to be testing. And also that there's normative standards that we can compare to. So as you'll see on the next slide, I'll talk a little bit about our scoring process. And in order for us to be able to feel confident in giving someone a particular test, we want to make sure that we can have some data to compare your results to. And so the test data is all the raw scores are converted then to standard scores. And this is a really busy slide. We won't go into the nuances of it. But basically, all the test scores are compared to people same age, same sex, and when possible, same level of education and ethnicity. So that really allows us to be able to know how an individual is performing on a particular test compared to their peers. So if someone's 50 years old, it doesn't make a ton of sense, or it's not very helpful for us to compare them to someone who's 80 or to someone who's 15. That doesn't tell us a lot about their functioning, because unfortunately, as we age, we expect there to be some cognitive changes. So we use this normal distribution here. As you can see, it's sometimes called a bell curve. It basically shows that there's a natural distribution in scores across a population. So for something like an SAT or the GRE, we know that most people would fall in that average range where the highest peak is. And as we go to the left and the right, fewer people fall in those directions. So it helps us to see where your scores are compared to your peers. So in terms of the interpretation is really important. So after all of the testing is completed and the neuropsychologist scores the test data for several hours, we work on interpreting the data, making sense of what all these numbers mean. And the interpretation is highly individualized, meaning that it does not follow a cookbook approach. So the interpretation is based on information from the individual's history, direct observations that we see during the testing session, specific scores, levels or patterns or test patterns. So we like to not just look at one particular score, but we really want to see a blueprint, see a kind of a pattern of scores across the board. And we also interpret those scores in light of current theory and knowledge regarding what we know about different conditions. And so when possible, we make judgments regarding the nature of the deficits or the patterns of strengths and weaknesses. We also try to identify the source of or any contributors to the deficits or the patterns that we're seeing. And we also like to make judgments regarding the relationship to the patient's presenting problems and what that means for treatment, what that means for prognosis moving forward. So the neuropsych reports, if you've seen them, can be quite lengthy. They do vary from neuropsychologist to neuropsychologist, and despite the differences in report style, generally the components are the same. So the goal of the report is to be able to describe the patient and report findings. We want to be able to interpret the test performance in light of the assessment information, so the information that we've gathered from the testing session, but also other information that we have about the individual. We also like to incorporate the nature and the source of the concerns, make recommendations for the future, and importantly, communicate the results not only to the provider, the person who requested that you have the evaluation, but also to the patient, to the family members. So after all these steps are completed, the testing, the scoring, interpretation, the report, it's time for feedback. And I personally really value this time because it's a chance to meet face-to-face with the patient and the family member to really talk about the results. Because at the end of the day, we want to know how we did. And it's important to be able to communicate those results to the individual. So during that session, for me personally, usually lasts about an hour. And I take advantage of the time to be able to talk about the current concerns, why we did the evaluation, sort of review everything, and really spend a lot of time talking about the implications of the data and any recommendations that I have. So let's talk a little bit more about neuropsychology and epilepsy. That's why we're here. So according to the National Association of Epilepsy Centers, neuropsychologists are an important part of the treatment team alongside with the epileptologists, the neurosurgeons, the nurse specialists, the EEG technologists, social workers, everyone who has the special training and experiences in epilepsy treatment. And so the role of the neuropsychologist in evaluating individuals with epilepsy is essentially the same as many other neurological conditions. But the reason for referral can often depend on the age of the patient. So in the younger folks that we see, in children, adolescents, more often than not, there are a lot of school or vocational planning concerns, whereas adults and older adults, we often see more concerns with cognitive deterioration and or job performance or planning for the future. So what's the purpose of the neuropsych evaluation? So as I've alluded to in the past, we are trying to create a blueprint we're trying to provide a blueprint as to someone's cognitive strengths and weaknesses. We want to help determine if there are any neurodevelopmental or neurobehavioral disorders that exist. We want to better understand any psychological or psychiatric factors that may be impacting cognition, because we know that there are many psychological factors that certainly co-occur in individuals with epilepsy, with depression being the most frequent co-occurring condition. We want to assess the functioning and use that information to assist in making any educational and vocational recommendations. We want to be able to evaluate, is there any concerns or any side effects from any AEDs that someone's taking, because we know that there may be some changes in attention or concentration or different aspects of processing speed. And we really want to be able to monitor changes in cognition and behavior over the course of a chronic disease such as epilepsy. So there are a variety of factors that impact the test results. And the test results are frequently determined, like I said, by multiple factors. And some of these may be the underlying cause of the epilepsy. So maybe someone's epilepsy is caused by tumor or by stroke. So knowing why, if we can, why the epilepsy is occurring is really helpful. Also, the location and the extent of the lesion is important in the test results. The age of onset and the duration of the seizure disorder, the seizure type, any adverse side effects from AED treatment, like I mentioned, and the psychological and emotional adjustment. So as psychologists, we are really interested in better understanding that. And so my job is to really understand how all of these factors contribute to the individual's presentation and treatment planning. So the location and the extent of the lesion or lesions causing the epilepsy are important variables that can really affect the type and the severity of cognitive impairment that we see. So the patterns that we expect to see are directly related to what we know about the brain. So again, as neuropsychologists, we are studying brain behavior relationships. So we want to know how a lesion to a particular area in a brain may cause some behavioral difficulties. So here are a few of the more common signs and symptoms of focal epileptogenic lesions. So if someone were to have lesions primarily originating from the mesial temporal lobe structures, that's an area that's really responsible for new learning and memory. So in those folks, we will often see difficulties in learning and memory. Someone that has more of a right parietal lobe lesion, they may have more difficulties in constructional skills, more spatial skills, kind of visual spatial perception. Someone with lesions in the left parietal lobe may have difficulty with higher cognitive impairments in things like language, reading, writing, calculation, and other verbal skills. Prefrontal lesions may lead to difficulties in executive functioning skills, like I mentioned before, planning, organization, problem solving, flexibility. Precentral or premotor epileptic lesions may lead to lower or upper extremity weakness and some difficulty in the integration of complex motor activities. And lastly, occipital lobe lesions may lead to difficulties in visual perceptual deficits. But as we know, in individuals with epilepsy, not everyone has a specific lesion focus, but these are just some helpful, some common test patterns that we do see. So neuropsychologists also participate in evaluating patients who are being considered for surgery. And the neuropsych evaluations help to provide a baseline for pre-surgical workups. And the evaluation may also help us to lateralize and, if possible, localize areas of weakness or concern to a particular side of the brain or to a particular region. So for most people who are right-handed, language and verbal skills generally live on the left side, and visual skills, nonverbal skills, generally live on the right side. So as neuropsychologists, we are trained to be able to assess, are there any, does someone's pattern of strengths and weaknesses, does that suggest that the left side or the right side is weaker than the other? And even more specifically, if possible, localized to a specific part of the hemisphere. We are also asked to help identify cognitive risks for surgery. Again, further identify barriers to treatment, whether there are any psychiatric conditions that may impact treatment. And in some cases, neuropsychologists also participate in WADA testing. And during WADA testing, one side of the brain is temporarily put to sleep, and this allows us to further assess language and memory. So I've said a lot already this evening, and I really hope that I've been able to help you understand what neuropsychology is, what our evaluations entail, what the results tell us, and how neuropsychologists play a role in the treatment of epilepsy. These evaluations can feel very intimidating, but hopefully you understand as a result of this presentation the role of these evaluations and that they can be really helpful in your treatment. So I am going to open it up, see if there's any questions. If I can do that.
Yeah, this is Ellen.
Hi, Ellen.
Hi, thanks for your presentation. I do have one question.
Yes.
Do these neurological tests on do they do these neuropsychological tests on young children, like elementary kids?
Yeah, absolutely. That's a really good question. And so neuropsych evaluations can essentially happen at any age. So yes, they would look very different for a young child than they would for an adult. But certainly the evaluations that may be conducted in a child may weigh more heavily on academic concerns. So these evaluations may be much more specific about the way someone reads, or their language skills, how they process information, because it can have really significant implications for education.
Great. Someone said these have a lot of different parts. Are they broken into multiple visits?
That's a very good question. And so it really depends on where you have the evaluation conducted. And I can speak for me personally. I try to do everything with the patient in one visit. I figure that the fewer visits to our office, the better. So generally speaking, we will have the patient come in for the evaluation in the morning, and then we'll do the interview first and then have the testing session after. So after the testing session is complete, the patient is free to leave, and the neuropsychologist then does all the work on the back end, and then they'll come back again for the feedback.
Okay. How often do you recommend redoing neuropsych evals, especially in children? Do you think it's better to have a neuropsychologist have assessments done, or a school psychologist, or does it matter?
Yes, so that is a very good question. I think there are a couple parts of that. So I'll try and talk a bit about the timeline. So repeat evaluations can be incredibly helpful, especially if there have been changes in behavior or changes in cognition, or if there's been some sort of intervention, whether it be therapy or some surgical intervention. And, there are certain retest parameters that we are encouraged to follow. So we don't like to give someone an evaluation, in May and then give them the same evaluation again in June, unless there was some significant reason to do so. But generally speaking, we would say, about 12 months for an evaluation, and then to be seen again if there were concerns or changes. And then in terms of the question regarding the school psychologist, I believe it was a school psychologist versus a neuropsychologist. So there are psychoeducational evaluations that can be done by a school psychologist, oftentimes within a school system. And those evaluations are very good, and they have a lot of really great qualities to them. The neuropsych evaluations on an outpatient basis may be able to provide a little bit more information to look at academic skills, but also all of the other cognitive ability areas that I had addressed. So I hope that answers that question.
Yeah, and do the test results change with age?
So the test results, the implications of the test results certainly do change with age. So, the recommendations that we would make for someone who is in 5th grade would be very different for someone who is 50 years old. So the results change in terms of the reason that we're seeing the patient, but we interpret the data essentially in the same way.
Okay. Do you recommend that all children with epilepsy have it done?
So I often recommend that this is a decision that's made with the patient and the epileptologist. They are, very well trained at being able to identify when these evaluations are appropriate. And so I kind of defer that question to them. So maybe either Dr. Husain, or Dr. Kohler may be able to follow up on that.
This kind of goes with it. If a doctor doesn't suggest that the patient have one, then how do you know when you should request one?
I think it's certainly a conversation to be having with the doctor at any time. If there's any concerns, if there's any reason to suspect that this may be beneficial, I personally think that these evaluations can be really, really beneficial. I think we just need to be clear on the reason for doing the evaluation.
Now, how do you go about getting these tests for your young children? I know that there's probably not a lot of child neuropsychologists in the Lehigh Valley. So how do you go about to get one for your young child?
Yes, and so that's a good question. A lot of the I'm much more familiar with the adult evaluation. So in terms of the pediatric, the child-focused evaluations, the epileptologist may have some information on who may be beneficial for that, but I know in places like CHOP, they have an excellent neuropsychological department that they can, really tailor these assessments to the individual's needs.
Okay.
There are also some individuals in the community who are capable of doing these evaluations as well. I believe also, I think Good Shepherd has a pediatric neuropsychologist too.
Okay. Are you able to do any of these tests through telehealth?
Very timely question. So the short answer to that is no. The administration of these tests are incredibly standardized, down to the words that we use and the angles in which we showed specific tests. So, it's an area of the field of neuropsychology that's growing, obviously in light of everything that's going on. But right now we are not providing any neuropsych assessments via telehealth.
Are you finding that this testing is covered by most health insurance companies?
Mm-hmm. Yeah. Yep. As long as there is a medical reason for the evaluation, we generally have no problem getting these covered by insurances.
Do you ever evaluate someone that has non-epileptic seizures?
We do. Yes, we do. Those evaluations can also be helpful in still determining someone's cognitive profile, because I'm guessing Dr. Husain will touch on this a little bit, but there are a variety of different things that we can identify as a result of the evaluation that may be informative and helpful for treatment. So yes, they can be helpful for individuals without epileptic or with non-epileptic events.
So we're running out of time. I probably have just time for one more question. Do schools accept the use of your evaluation result and add it to their child's education plan?
In most districts, yes. There are always some small nuances from district to district, but in most cases, absolutely. The thing to just be careful of is whether a school psychologist is conducting an evaluation simultaneously. And if that is the case, it may be helpful for the neuropsychologist that you're seeing in the community to know about that, so they're not repeating any measures that the school psychologist also did, because that would invalidate some of the data.
Okay. All right, there are a few questions here that we didn't get time to answer. So if someone here felt like they didn't get their question answered, you can pose it again and we'll see if we have time. We have a break coming up after our next speaker, or maybe the next speaker would be better able to answer that. But thank you very much. That was a really enlightening talk. I really appreciate it. There's Dr. Husain. Let me share. So thank you, Shannon. Are you going to stick around for a bit?
Yes, I am.
Okay, wonderful. And so, yeah, there might be 5 or 10 minutes after Dr. Husain for any more questions that need to be addressed.
Yes, thank you.
Thank you. Okay. Dr. Husain, are you still there? I don't see you now.
Oh dear. Let me try this one more time.
Oh, there we go. Good.
Okay, good. Still see me?
Yes.
Good.
Rather than share you're going to share your screen, correct?
Yes, I am.
Okay. The only screen I have is to introduce you, so we're not going to put that up.
Okay. Can you see my presentation?
Yes.
Perfect. Okay,
Wonderful.
so I'm Dr. Husain. I'm one of the new epilepsy specialists in the Valley. And
Dr. Husain, I was going to introduce you.
Oh, thanks. Perfect.
I just wasn't going to put up the screen.
Okay, understood.
Okay. Dr. Husain's an epileptologist who's affiliated with the Lehigh Valley Health Network. She graduated medical school at Wayne State University School of Medicine and completed her neurology residency at Rush University Medical Center. She completed her clinical neurophysiology and epilepsy fellowships at McGaw Medical Center of Northwestern University in Chicago. Dr. Husain is board certified in neurology and clinical neurophysiology and a member of the American Clinical Neurophysiology Society, the American Epilepsy Society, and the American Academy of Neurology. Her interests include user interface design, website development, art, and creative writing. Thanks for being here, Dr. Husain.
Well, thank you for having me. So my presentation is a little bit down to brass tacks. It's about whether something is a seizure. So let's get into it together. I have no disclosures. And the reason for this talk is that epilepsy specialists often get asked about clinical symptoms. And for our patients who have a known diagnosis of epilepsy, this might be to understand if new symptoms that they are presenting with are part of their epilepsy, if they are epileptic seizures. For patients who are new to us, who might not have a diagnosis of epilepsy, often they come to us themselves or they're referred to us to ask the question if a set of symptoms that they're having are epileptic seizures. And in both cases, the first and the most important step in answering this question is to get a detailed and accurate description of the episodes. And essentially, as neurologists and epilepsy specialists, we have 3 tools at the onset to try to triangulate what's going on. And part of that is the clinical story. Part of that is the EEG, and part of that is imaging like MRIs. But this is, I think, in our partnership with our patients, one of the things that's the most immediate and the ways that the patients can help us the most in getting a handle of what's going on and answering their questions. So to start with, an accurate description will help us determine, number one, if the set of symptoms that they're describing are actually epileptic seizures or they're seizure mimics. And that's important because if they're not epileptic seizures, treating them with seizure medications isn't going to help. And identifying early on that something is not an epileptic seizure could potentially spare our patients from unnecessary treatment. If we determine that this is likely to be an epileptic seizure, a good description, often before I can even get an EEG or an MRI, can tell me what type of epilepsy this patient has, which is important because, as we'll get to later, there are certain types of epilepsy in which certain medications are not appropriate, and I would love to avoid those medications. It would let us identify if there's more than one seizure type. So for example, some patients with very long-standing and uncontrolled epilepsy might develop seizures from a new location on the other side of the brain. And if there's a clinical change in their seizures over time, we might be able to identify that by story, again, before we even get EEGs or other testing. And then also, where in the brain the seizures are coming from. And this is one of the essential tools that we use to help planning for surgery for patients who have medication-resistant epilepsy, a tool to help us understand where to narrow our focus as we're trying to pinpoint an area of the brain that we want to treat with surgery to help hopefully cure the epilepsy. So there are 2 really important parts of this picture in order to get the full 360-degree picture. I talk to the patient who experiences symptoms that the rest of us can't see just by looking at them. And then because many of my patients tell me that there are periods of time during their symptoms that they are unaware or they're unconscious, it becomes really important to also have a witness available, if one is available, to discuss what it is that happens while the patient is not aware of their surroundings. So what I recommend is when there's a first visit with any new neurologist, to always have either a person come in with you who's seen the seizures or have them available by phone for questions. So to get down to the nuts and bolts of the description and the types of questions that might make a difference in how I understand what it is my patients are telling me and help kind of narrow down what it is going on, the first thing I ask them to think about are warning symptoms. So these are symptoms that the patient will experience before the main event. Some patients have their episodes, whether they end up being seizures or other types of episodes, happening without any kind of warning at all. And for some of them, there's a clear warning before. So I like to know, if there is, what that warning is. Is it a smell or a taste? Is it a sound? Is it some type of visual abnormality that they see? Is it a physical sensation somewhere in their body? Is it an emotion, a feeling, or some kind of strange experience? And in many cases, there is more than one, and it becomes really essential to know what order they occur in. I ask patients how long there is between the warning symptom and the next set of symptoms, what I kind of jokingly call the main event. Do they have time to warn someone? Do they have time to sit down? And then another key question is whether the symptoms, the order that they occur in, and the duration is the same each time around. Also, is the warning there every time they're going to have the additional symptoms? And related to that, do the warning symptoms ever occur in isolation? Do they occur without the main symptoms? And so what I've been jokingly referring to as the main event, these are the symptoms that are often visible to other people. And so again, this set of questions applies both to the patient and to the person who's watching the seizures, the witness, who's able to give me additional history. So number one, what are the symptoms? Are these episodes of staring? Are these episodes where there are abnormal movements? And if so, what kind of movements? Do they start in one spot in the body and then spread? Do they start everywhere all at once? Is the tone abnormal? And this usually means that someone either goes limp or goes rigid. Do they lose consciousness? Do they fall? For the person who experiences these symptoms, I ask about the level of awareness. If they know that the symptoms are happening, do they feel themselves staring off into space, for example? Or is it that someone has told them that after the fact and they're telling me? Are they able to talk during the episodes? Are they able to understand what others are saying and then remember what they said afterwards? And if they're falling, do they feel themselves falling and do they feel themselves hitting the ground? In other words, are they unconscious even before they fall? And again, if folks have more than one of these symptoms, the order that they occur in and the amount of time that each of those symptoms lasts can be a potentially very important clue, both in understanding in the moment how the seizure is progressing in the brain if it's an epileptic seizure, but also potentially for future planning if we need additional treatment such as surgery. And that other key question that we talked about before, is all of this the same every single time? The symptoms, the order, and the duration. Sometimes during epileptic seizures, as well as other types of episodes, there are other symptoms that happen. For example, there's a tongue bite, and if so, sometimes we get important clues by knowing which part of the tongue is bitten, whether it's the front, the left, or the right side, whether they lose control of their bowels or bladders, and whether the person who has a seizure has ever been injured, and what's happened. Are there bruises, cuts, burns, broken bones? And unfortunately, all of those things do occur. Potentially, another very important clue is the symptoms that occur afterwards. So sometimes people have a loss of consciousness and immediately afterwards are almost perfectly back to normal. They might be confused about what happened, understandably, but they're not confused in that other sense of the word where they're not thinking as clearly as they would normally think. So if there is a recovery period, how long does it last and what are the symptoms? Is the person fatigued? Are they confused? Do they have a headache? Do they have muscle soreness? Do they have language issues? And if so, what type of language issues? Is it understanding what other people are saying? Is it being able to find the word that they want to say? Is it stuttering? Is it something more like saying real English words, but the context doesn't make any sense? And the other question is, are these symptoms the same every time, or does someone sometimes have confusion or fatigue and other times they're perfectly normal? So one way that all of this information gets filtered, and to be honest, the first thing that an epilepsy specialist has to do in processing all of this information, the first decision point is determining, is this an epileptic seizure or is this a seizure mimic? And when we're discussing epileptic seizures, what we're describing is an abnormality of the brain's normal electrical rhythm, and it may produce symptoms that are either seen or experienced. However, a non-epileptic episode also has symptoms, and in many cases, those symptoms might mimic some of the symptoms that can be seen with epileptic seizures. However, they're not caused by an electrical abnormality in the brain, and that becomes apparent when the patient is connected to EEG. So when we talk about non-epileptic episodes, we can split them into two broad categories. And those are the physiologic non-epileptic episodes and the psychogenic non-epileptic episodes. So the first category, the physiologic non-epileptic episodes, are caused by a different physical condition that's not epilepsy. So some of those could be syncope or fainting, movement disorders, especially movement disorders that have a tremor or a dystonia in which there's an abnormal stiffening or tone of the body. We can see cataplexy, which is a condition that we see in narcolepsy where people suddenly drop when they experience strong emotions. We can see complicated migraines, which are migraine headaches associated with stroke-like symptoms, and they're the same stroke-like symptoms every time. And what makes that diagnosis sometimes more challenging is that people who have complicated migraines sometimes might not have the headache part associated with the rest of the symptoms. In young children, we can see breath holding spells where they might turn blue or white, and we might see shuddering attacks. The biggest category that we see in an epilepsy monitoring unit and in our practice of things that look like seizures and certainly sound like seizures, but are not epileptic seizures, are psychogenic non-epileptic episodes. And these are caused by a problem of emotional processing or integration. They're involuntary, so the person who is experiencing them is certainly not doing them on purpose. They're a reflex response to distress. And they're often occurring in a history of trauma, anxiety, or depression. So because the cause of these episodes is different than the cause of epileptic seizures, they're not going to respond to medications for epileptic seizures, which modulate the abnormal electrical activity in the brain. Since that's not the root cause for psychogenic seizures, what we often see is patients who are referred to us for what is billed as epileptic seizures that have not responded to treatment. And as we dig deeper, we recognize that the reason that they have not responded to treatment is because the diagnosis was incorrect and they were really psychogenic non-epileptic episodes. There is a strong body of literature that these episodes do respond very well to therapy. And in particular, it's a very particular application of a particular type of therapy called cognitive behavioral therapy that has been successful for these patients. Now, I will take a moment because I think it's important to talk about terminology. These types of symptoms have been around for forever. And because of that, they have been called many different things that are all the same. The word that has fallen out of favor with very good reason is pseudo-seizures is not something that we use anymore, but it does describe the same condition. And part of the reason that it has so strongly fallen out of favor is that it's not kind and it's not accurate. It doesn't really reflect that people who have these episodes are not doing them on purpose. They're just as unexpected and scary and unknown and unpredictable as for patients who do have epileptic seizures. I've seen in my practice that there are some patients who call these non-epileptic seizures, and while I think that that's kinder and more accurate, I do think that there's a practical concern with that, which is that sometimes when these patients end up in the emergency room or with other physicians, they might only hear the seizure part of the diagnosis. And I think that there's a very real risk of unnecessary treatment with seizure medications that have the potential for side effects but don't really have the potential to do much to stop these episodes. Now, one of the really important things to recognize for both physiologic and psychogenic non-epileptic episodes is that both of these can occur in patients who have epilepsy. So in our patients who do have known epilepsy, who are coming to us with a description of another type of episode, we have to be careful because patients who have epilepsy can have multiple seizure types, but they can also have fainting, just as people who don't have epilepsy can have fainting, and they can have psychogenic non-epileptic episodes brought on by the medical trauma and the stress of their diagnosis and some of the realities of living with epilepsy. So it is always something that we have to be aware of, and always something that, again, goes back to taking a really strong history and having a good understanding what the baseline epileptic seizures are, to be able to understand how these other episodes are similar and how they're different. So let's say that at that decision point, we went to the other side and thought that these were epileptic rather than non-epileptic. Well, in that case, often in that first interview, we're able to determine what type of epilepsy it is. So again, with broad strokes here, the two main categories that we're looking at are generalized epilepsies, that when the seizures start, they start everywhere in the brain all at once. And that is in opposition to focal epilepsies. In that case, when the seizures start, they start in a small region in the brain and they spread from there. In generalized epilepsies, we have a smaller spectrum of different seizure types we can see. We can see absence seizures, which are brief episodes of staring with no warning before and no confusion or fatigue afterwards. There can be myoclonic seizures, which are brief one-off jerks of various limbs that don't affect the level of consciousness. We can see atonic seizures, where someone suddenly becomes limp and falls down. And then we can see generalized tonic-clonic seizures, and these are the ones where someone loses consciousness, stiffens, and has full body shaking, sometimes with a loss of consciousness and sometimes with biting of their tongue. On the other hand, with focal seizures, we have a very broad spectrum of possible symptoms that we might see. And often what we find is that there's great variability from individual to individual, but there do tend to be patterns for one individual. So the specific symptoms that we see depend on where the seizure starts in the brain and how it spreads. If the seizure spreads to both sides of the brain, it may cause loss of consciousness, shaking, and tongue biting or incontinence. So again, a seizure that can start as a focal seizure can produce a generalized tonic-clonic seizure. And it becomes really important when I meet with a patient, if they tell me that they have grand mal seizures, to really dig deep and understand, did that seizure start out of nowhere with no warning symptoms? Or did it have an aura before it and some symptoms like staring and unresponsiveness leading up to it before they went into the rest of that seizure? An epilepsy specialist will use this description to map the symptoms onto the brain and, oh, it looks like it cut me off there, and determine the pathway that this seizure is taking. And that becomes really essential in an evaluation for epilepsy surgery, to begin to understand where in the brain we should be focusing our attention to really pinpoint where the seizures are coming from. So I hope that this works. I have a couple of examples, if you can still see my screen, and these are all on YouTube, so not violating any past or current patients' privacy, but so we could get some practice together, real practical practice of going through several seizure types. So these are all epileptic seizures, and here's the first one. And let's see if I can make it bigger. So you can see that he has this bouncing, and it seems like at the moment it's mostly in his toes and in his feet, causing higher up on his leg to bounce as well. But now it seems to be spreading up his leg, more up into the upper leg and the thigh, causing the whole leg to bounce. Now, we don't have any sound for this video, so you'll have to take my word for it. But that patient was awake and aware and able, and typically a patient like that is able to narrate their symptoms. And so that is a focal seizure. It is a motor seizure. Sometimes the patients might describe a somatosensory aura, which is a feeling, a physical sensation in the limb before the seizure starts. And they would describe that there is a movement that begins on one part of their body and then spreads up their body. In this case, it's his leg. And that would tell me exactly in the brain where his seizure is coming from, because it is coming from his motor strip on the other side of his brain. Here's another example. This is a quick one. All right, so a very quick one, but that was a myoclonic jerk. So this was a single one-off jerk of her arm that occurred early in the morning. She was eating her breakfast, and it wasn't associated with a loss of awareness. Typically, these patients wouldn't have any warning symptoms before or any post-event symptoms afterwards, and it would be just that one-off jerk. And that is a huge clue to know about as an epileptologist, because that tells me that she has a generalized epilepsy, that there are certain medications that I'd like to avoid for that patient, that that she's more susceptible to certain triggers like sleep deprivation and alcohol, and I can warn her about that susceptibility, and that I can use the EEG for her as a slightly different type of tool than I can with a patient with a focal epilepsy. So this one's kind of interesting. It's from the perspective of the patient. So we have to imagine that we are walking down the street. And so this patient is experiencing a visual aura. So we can see that there is a flash of light along the outer corner of the right side of the vision, and then followed by colors and shapes. And that is also a huge clue. This would be a seizure, and it is coming from the primary visual area on the opposite side, so on the left side of the brain. And then this one is a little bit more complicated. This is a seizure that someone took while he was in an epilepsy monitoring unit. And let's watch it together and see what we see. So we can see that he's coloring. He is awake and with it. And then all of a sudden, his head turns to the right over his shoulder. His right arm was jerking, and then it stiffens. Oh, I'm going to pause it right there. Oh, darn it. Well, we're going to watch it again together, I suppose. But his right arm had extended outwards, and his left arm had bent at the elbow, which is a very strong clue that the seizure had started on the opposite side of his brain. So Dr. Kelley had alluded to this in neuropsychology, but in terms of watching the seizure behavior, this is a lateralizing sign. It tells us the seizure occurs on the opposite side. Now he's going to stiffen, and he's going to begin to shake. So this is a generalized tonic-clonic seizure. It comes with a head turn to the right, right before he goes into it. And there doesn't seem to be a warning because he was fine up until the moment that he turned. Sometimes people who have that head turn right before they go into the seizure are aware and feel the very beginning of that head turn before they lose consciousness. And knowing if they do can be a huge clue to me about where on the other side of the brain the seizure is coming from. All right, well, those are some of the more interesting videos that I can find. Do you have any questions for me?
Hi, Dr. Husain.
Hi.
It's Ellen again. Let me just get to the chat button here. That was fantastic. Thank you so much.
Oh, thank you. Well, I'm glad that the technology cooperated.
Yes, wonderful, wonderful. It was like you were doing it for years, you know, the video. Are there times when diagnosed as generalized seizures, they're actually focal?
So
Is there
absolutely.
Okay.
And this becomes, you know, if I can get on my soapbox here, I can give you an example from my own experience about why the story is so essential. So on the EEG, certain types of epilepsy coming from the frontal lobes of the brain can have the same EEG pattern or a similar EEG pattern to the EEG pattern that we see in a generalized epilepsy. However, the story will be quite different. So unfortunately, during my fellowship, I have a very strong recollection of this young lady who came to see me who had been diagnosed with epilepsy something like 11 years before. And she had what was billed to me as a generalized epilepsy. And then when I asked her about her seizures, she told me that her seizures would wake her up in the middle of the night because her right leg was jerking. And that right leg jerking, just like the patient that you saw in the video, spread up her leg. And as it was spreading up, it came up her arm, and then her face started to turn to the right, and then she lost awareness. And so it was very clearly not really a generalized epilepsy. It was a focal epilepsy coming to the frontal lobes. So yes, we can see them misdiagnosed both ways, unfortunately.
Someone was asking about other tests other than the EEG for testing besides the EEG. What other tests are there?
Well, to be honest, the EEG is really our bread and butter. And the way that I describe it to my patients is that there are 3 tools that we use in triangulation for most of our patients. So we use the description of their seizures, and the fancy medical word for that, which even within neurology is a bit contested, is called semiology. But it basically boils down to the seizure description. We use the MRI and we use the EEG. Now, in somebody who has a generalized epilepsy, the seizures are coming from everywhere in the brain at once. So the MRI, often, we're just getting to prove that there's nothing there. We don't expect there to be something, and we don't want there to be something. Somebody who has a focal epilepsy might have an abnormality on the MRI that fits with what we see on the EEG. Now, if they respond to medication, that pattern on the MRI doesn't necessarily come into play. However, if they prove to have medication-resistant epilepsy, then finding something that is an abnormality on the MRI counterintuitively can be a huge benefit, because that means that the person has a better chance of seizure freedom after surgery.
I've had this question a few times. People curious about the difference between a neurologist and an epileptologist. Some people have never even heard that term before.
So an epileptologist is a neurologist, but after they complete their years of neurology training, they get additional training in managing patients who have epilepsy and reading their EEGs. So the way that I describe it to my patients is, this is all I do all day long.
Okay.
I think that one really important thing to remember is that 60 to 70% of folks with this diagnosis are going to be well controlled on their first or second medication. And so there are many patients who might continue to do well with their neurologist. However, for special cases, for pregnant women especially, folks who might have a more complex presentation, so epilepsy in addition to intellectual disability or unusual features, they might benefit from seeing an epileptologist. People whose seizures have not come under control after 1 year of treatment or after trying 2 medications should see an epileptologist.
Great. Can a person who's diagnosed with epilepsy also have episodes that are psychogenic?
Absolutely. So there is a strong body of literature that describes that there are people who have both. The exact numbers vary depending on who you read, but anywhere between 8 and 40% of people might have a combination of both. And that's another reason that collaboration and information become really important, because the most successful patients with both can understand the difference between the two. They can recognize their non-epileptic symptoms as non-epileptic and say, okay, well, I guess I need to double down on the cognitive behavioral therapy and I'm going to go for a walk and calm myself down. But if they have an epileptic seizure, then they call me to say, yeah, I think I need to go up on my medication.
Okay. Does Lehigh Valley Health Network have an epilepsy monitoring unit?
Oh, of course.
Okay. I knew that.
Yes, we do.
Someone said that they heard that an aura is now a new type of seizure and no longer viewed as a warning sign.
An aura is a seizure. So it often helps to frame it as a warning sign, but an aura absolutely is a seizure. So in a focal epilepsy, the way that the epilepsy propagates is that the cells that are involved do something that is very unusual and very abnormal, which is that they release their electric discharges all at once in sync. And normally our brains are supposed to be organized chaos. So those cells fire and stop, and fire and stop, and fire and stop. And that pattern can pick up and create the seizure. And the first symptoms that we see depend on which area of the brain it is and what it controls. And as those cells that are going recruit their neighbors around them in a circle, those cells start acting up as well, and they might contribute their own symptoms. And then the cells around them can also start going. And that's the way that a seizure propagates. So those aura symptoms are actually the first part of the seizure. And often in my treatment of patients, I tell them that if they have their aura, I need to know, because that's a clue that we're not quite there with treatment and we need to aim higher. We can use that aura as a clue to wipe them out, even though they're not problematic or disturbing to the patients, but to try to prevent the bigger seizure that's trying to brew.
Wonderful. There are so many questions on here. But I think we have to move along for our next speaker. And I was wondering, would you be sticking around until the end? Or would you have somewhere to go? Okay, because I'm going to save some of these to the end. And I'm sure if you can't, then Dr. Kohler might be able to answer them. But I thank you so much. It was very enlightening. It was a great talk, and I thank you very much.
Thank you so much.
All right, take care. Okay. Oh, I look very bright. Sorry about that. So our next speaker is, is Dr. Kohler, and I want to introduce him. There he is. I like that painting behind you.
Oh, thank you.
So let me take myself off the camera here. Okay, so I'm going to introduce Dr. Kohler. Dr. Kohler is an epileptologist who's affiliated with St. Luke's University Health Network and is the co-director of the Epilepsy Center at St. Luke's. He graduated medical school from the Temple University School of Medicine and completed his neurology residency, clinical Neurophysiology Fellowship, and Epilepsy Fellowship at the University of Virginia. As an epileptologist in the Lehigh Valley, Dr. Scott Kohler specializes in the comprehensive care of patients with epilepsy and seizures. He is board certified in neurology and clinical neurophysiology. He's a member of the American Academy of Neurology and American Epilepsy Society. He grew up in Berks County and enjoys spending time with his family, camping, and spending time outdoors. So thanks for coming, Dr. Kohler.
Absolutely. Thanks for having me. And I think this is great that we're still able to do the conference through video, even though we can't meet in person. So allow me to try to get my slides up here. I believe, are you able to see my slides? No?
I don't see them.
Okay, let me try again.
Do you see them, Rena?
I don't see them yet.
This share screen at the bottom there?
Yeah, I did share screen.
Starting.
Is that better?
Yep, there we go.
All right, and try to get the slideshow. You can see my slideshow now?
Yes.
Perfect, okay. So we're going to be talking about comorbidities with epilepsy. And in addition to obviously working on treating the seizures, we also want to make sure we're treating all aspects of things that go along with epilepsy. So I don't really have any fantastic disclosures. I have no financial interests in anything. I do work for St. Luke's, but that's kind of the only thing that is worth note. I guess, kind of disclosure is, you know, the topic of comorbidities and epilepsy, if anybody knows me well enough, you know that I like to talk, and I could make any one of these topics probably an hour if given the opportunity. But, you know, we are going to talk about a lot of different things. And it's really, you know, as a brief overview, and it's really important for you to talk with your neurologist or your epileptologist, if you're following with one, about any special concerns or how any of these would apply to you. So we're going to be talking about different disorders, complaints, and problems that people with epilepsy often experience. So things that often go along with their epilepsy symptoms, not just their seizures. So you will talk about some science, but we'll also talk about some practical things that would be helpful for you to talk with your doctor about when you're seeing them in the office. So just with everything that obviously everybody is dealing with, I think it's worth note to mention at least a little bit about COVID-19. Obviously, that's the reason we're doing the conference virtually right now. And it's important to note that for people with epilepsy, epilepsy itself does not affect your immune system, and having epilepsy does not make it more likely that you would get the COVID-19 infection, and it also does not mean that your illness, if you would get infected with it, would be more severe. So even though epilepsy is a chronic medical condition, it's not one that would make you at a higher risk or make it more dangerous for the COVID-19 infection. Obviously, that has to do a lot more with other medical conditions or problems with the immune system. Now, some people with epilepsy may also have those conditions that would put them at a higher risk, and that wouldn't be linked to the epilepsy, but to those other conditions. People who would develop the COVID-19 infection or get that, if they do have seizures, and for some people, as you may know, if they are sick with things like the flu or other illnesses and have a fever, they may have more frequent seizures just from having the fever. And that may happen from the infection, but that likely has more to do with the fact that they're just otherwise sick and having an infection or have a fever. And that's kind of a common thing overall, but also is more common in children. So with this, it is important to make sure that you're still following the guidelines from the CDC with the same precautions that everybody else is using. And certainly if you have any concerns about your own care with that and how your risk may be, it'd be important to discuss that with your doctor. So going into things that we do frequently see and address in people who have epilepsy, one very common one is memory and thinking. And that gets a large part to do with and ties in a little bit with the neuropsychological testing that we heard from Dr. Kelley in the beginning of the conference. And, you know, common complaints that when we're seeing patients that they may say to us are all these different things. They may have trouble remembering with past memories. They may have trouble with their appointments. They may have trouble with names or faces. They may forget where they put things, or, you know, I think often people notice where they may walk into a room and forget why they walked into the room. But that could be more of a problem in people who have epilepsy sometimes. Sometimes they may have trouble with their thinking or cognition. Other common ones are difficulty with word finding, or one thing that scares the heck out of epileptologists is forgetting their medicines, because obviously we want to make sure that our patients are taking their medicines on schedule and not missing any doses. So the memory and the problems may have the same cause as the seizures themselves. So some people, if they have developmental disorders, so if their brain has developed abnormally, or if they had an injury to the brain early on, that abnormality with the brain may cause both their seizures and their trouble with their memory. So they may both be coming from the same cause. Similarly, if they have genetic abnormalities or genetic problems that are causing their epilepsy, that genetic problem which is altering how their brain functions may also cause them to have trouble with their cognition or thinking. They may get injuries to the brain. So sometimes in folks as they get older, if they develop a tumor or have a stroke, or if they've had a traumatic brain injury, some structural injury or dementia that's causing their brain to not function properly, that also can cause seizures. So again, those may come from the same cause. Now also, people can have trouble with their memory and thinking, partly related to the seizures, and we'll talk a little bit more about this. And some of that may have to do with how long they've had epilepsy and how long they've had seizures, or if they're having very frequent seizures, that may put them at a little bit higher risk or lead to some trouble with their memory and thinking. So really the cause of their memory trouble may be what we say multifactorial, may be a combination of a lot of these different things. So maybe I often call it a big knotted up ball, and we have to kind of tease out and start eliminating and treating some of these to overall try to get things better. And if there's still some left over after we've addressed one or two problems, then we need to focus on something else and untease them. So although we say that each individual seizure really doesn't cause any long-lasting injury to the brain, and really, you know, the reason we say that is because if we do MRI scans or tests that look at the structure of the brain after a seizure, as long as that seizure doesn't last for a very long time, typically we don't see any changes. And so we don't see any long-lasting injury or anything like that. But in people who may have long-standing epilepsy, or if they have multiple seizures, sometimes we can see changes in the brain cells themselves, or at least the networks, the pathways. So, you know, with this diagram on the right, the brain has multiple different functions. And you saw this from Dr. Kelley as well, that all the different parts of the brain may have different functions. And this is just to name, obviously, a very few, but, you know, your language areas. If you have seizures that are involving your language areas, that could potentially cause some changes in those neuronal networks, in how those brain cells are connecting, and can lead to that trouble with your word finding. Or if it's seizures that are involving the temporal lobes, that could interfere with, you know, primary processing of memory and things like that. Or if it's involving the occipital lobes in the back of the brain, that could also cause trouble where people may have difficulty with their vision or things like that. So it may not just be that there's an injury that we can see on the MRI, but there may be very small changes with how the brain cells are connecting with each other that by changing those connections changes how the brain works over time and may lead to some of these problems. And it may be something that's subtle, or it may be something that's more noticeable. So obviously the brain is complex, and this is, you know, oversimplification, but and just because we don't see problems on the pictures doesn't mean that there may not be things underlying. And two, that neuropsychological testing really can help us look not just at the structure, like how the MRI looks at the structure of the brain, but the neuropsychological testing helps us look at the function of the brain. So we can look and see these areas that we're looking at, are they functioning the way we would expect them to function? or is there a problem? And that can give us clues as to where the seizures may be occurring. Oops, sorry, my mouse is sensitive. So, for example, one area where we can sometimes see structural changes over time is in temporal lobe epilepsy. So these are seizures that are involved in the temporal lobe, kind of the part of the brain that's behind the ear. And these are some pictures of the brain. Now, these are coronal slices, so they're kind of looking at the brain kind of face on, as if you were looking at a camera. And what we're looking at is here on it's the right side of the screen, but it's really the left side of the brain with how we look at the MRIs. We can see that here's where the hippocampus is. It's the middle part of the temporal lobe, which is a part of the brain that's very important with memory. And we can see on this side, we don't see very much bright signal, which is the CSF. That's the fluid that surrounds the brain. You can see the fluid here in the ventricles, which are normal where we would normally see it. But here around this hippocampus, we see a lot more of that fluid, which tells us that the brain shrunk. And when the brain shrinks and goes away, we see more fluid. On this other image on the right, on this one, the fluid shows up dark. So we can see this dark over here. And it may not project very well, but the hippocampus actually gets scarred and shrunken and gets brighter on the MRI, especially on these pictures, the flare pictures on the right. And with the term we use for that is hippocampal sclerosis, which kind of means just scarring and shrinking of that hippocampus. And sometimes we can see that in seizures if they involve or spread to the temporal lobe, when that we can see those changes. And if the hippocampus is getting scarred and shrunken, that can lead to memory trouble. So how do we help these symptoms? Well, obviously a big one is we want to reduce the seizure frequency and avoid seizures. So avoid that long-term changes in the brain because of the seizures. And we can do that with medications, and we may do that with epilepsy surgery or other devices or other things if necessary. And by getting the seizures under control, often, at the very least, things may not get worse, but sometimes in some patients, not everybody, but sometimes even after, say, epilepsy surgery, where we remove the part of the brain that's affected, and sometimes even by removing the hippocampus, if it's scarred and shrunken, sometimes their scores on their neuropsychological testing can actually get a little bit better, or they can notice a little bit improvement in their function because we're getting rid of those seizures, we're getting rid of that problematic area. One other big thing is we want to minimize side effects from medicines, and we'll talk about this a little bit more also later on, but some medications may cause trouble with your thinking or cognition. They may have that as a side effect. So trying to either reduce the dose. Sometimes we need to switch to a completely different medicine because that medicine is just causing too many problems. Or sometimes if people are on a whole bunch of medicines, getting them just down on fewer number of medicines can be really important. And I think, any epileptologist can probably tell you that they've had this experience where they may have a person who's on, comes to them on 5 medicines and they're having a lot of cognitive problems, but even just by increasing some of them, but getting them off of others, so having them on higher doses of maybe 2 or 3 medicines, they actually feel better than on low doses of 5 or more. So we really try not to have people on too many medicines, and certainly we want to make sure that we're minimizing those side effects from the medicines themselves. And then other things are neuromodulation. So this kind of gets to some of the medical devices that we use for treatment of epilepsy, like the vagal nerve stimulator or the responsive neurostimulator, NeuroPace, or the DBS. They can help to kind of change a little bit of how those pathways are getting altered and try to get them to be in a more healthy pattern, a more healthy network that's maybe not causing as much of these cognitive trouble. And again, remember I said before that it may be multifactorial, maybe this big knotted up ball. So there may not be any just one fix. It may not be just medicines. It may not be just getting the seizures under control, especially if the medicines are causing trouble. So we may need to do multiple things to try to get things better. Other things that we pay attention to is people's mood and behavior. And a big thing that we often screen for in our epilepsy clinics are other psychiatric disorders. So, psychiatric disorders like depression and anxiety can be twice as common in people who have epilepsy as compared to people who don't have epilepsy. So it's very important for us to recognize these, because uncontrolled depression, anxiety, obsessive compulsive disorder, ADHD, psychosis, any of these can have a really big impact by themselves on people's well-being, and also in people with epilepsy. So it's really important for us to screen for these and address them if they're coming up. And some of these may be even more common in people who have intractable epilepsy, which means we haven't been able to get their seizures under control. So having uncontrolled seizures may make it a little bit more likely that people may experience these problems. If we don't address them, they can have a really big impact on people's function, on their life. So in children, if they have mood disorders, it could affect their school performance. It could make them less able to participate. It could affect family or friend relationships. Obviously work, it can impact quality of life. And again, getting back to that thing that's scary for us, it can impact patients' compliance with their medicines. Sometimes people, if they're having difficulty with depression or anxiety, they may not be as compliant with their medicines. And I always jokingly say the medicines don't work as good on the nightstand. They work better when you swallow them. So we really want our patients to be taking their medicines to try to help their seizures. So again, what are some things that can cause these? And some of it could be related to the seizures themselves. There is something that we call periictal depression, which periictal is a fancy doctor term for saying it's something that happens around the seizure. It's not the seizure itself, but it happens either before or after. And there's likely some changes with that brain activity that maybe isn't the electrical storm of the seizure, but there are some changes that families may notice. I can tell when a seizure is probably going to happen because his or her mood changes, or they start to notice other things. And we can see that sometimes even days before the seizures happen, these things can happen. Sometimes people may have symptoms similar to anxiety that are the initial symptoms from a seizure, from that electrical storm. I mentioned the temporal lobe is involved with memory, but it's also really involved with things like emotions. And the amygdala, one of the parts of the temporal lobe, is one of our fear centers and emotion centers. And people who have seizures that start in that starts at the very first moment in their temporal lobe, sometimes that can start with fear or anxiety. They describe it maybe as their aura, but just as Dr. Husain said, that's the very beginning of the seizure. That electrical storm starts in their amygdala and causes them to get fearful. I've had a patient who he would get up and try to run out the room when the seizure would start because he would get this really intense sense of fear. And that was the beginning of his seizure. And then there is a phenomenon called postictal psychosis, where after the seizure, kind of in the aftermath of the seizure, when the brain is no longer having that electrical storm, but it's kind of in the recovery phase, people can have symptoms where they can have hallucinations, delusions, aggressive behaviors, and things like that. And it's very important for your doctors to be aware of that, because we want to also make sure the patients are safe after their seizures and that we're addressing these types of mood trouble as well. Now, in addition to the seizure itself, there's a lot of other things that can go along with having trouble with depression or anxiety. And one big thing that we sometimes see is just the effects of the seizures themselves, which can limit people's ability to function, work, and drive. And losing some of that independence may itself be a source of anxiety or depression or changes in their feeling and their mood. Unfortunately, there still is a bit of a social stigma and some discrimination against people who have epilepsy, which may play a role. Sometimes because people may not be able to be out and about, there may be some amount of social isolation, or if they don't have very good social support, friends and family. I think all of us may be experiencing some of this with being stuck at home because of the COVID pandemic, but people with epilepsy, they may experience this even without the COVID pandemic, because maybe they can't go drive and be out of the house because their ability to travel has been impaired. And then two, sometimes just the stress or anxiety or fear of when the next seizure may happen itself may create some anxiety. Now, not just from the seizure or for the psychosocial, but there could be some biological causes. So again, if a person has had some structural or injury to their brain, or if there's a lesion or alterations in how their brain networks are transmitting signals, that can sometimes cause changes with their mood. We'll talk, I think in one of the later slides, specifically about the frontal lobe and how seizures can affect that. but also there is some evidence that people who have epilepsy may have lowered levels of serotonin or norepinephrine. And those are two hormones and neurotransmitters that are very important when it comes to depression. A lot of depression medicines target these two neurotransmitters to try to get them boosted, to try to help with mood. So it may be even at kind of a very small molecular and neurotransmitter level that there's a problem with the biology shared with the seizures that's causing the trouble with depression. And yet again, we kind of also mention about our medicines. You know, we want to be cognizant of the medicines that we're giving because those potentially have side effects, and we don't want to be making things worse with the medicines we're using. We're in the business of making things better. So we want to make sure that the medicines we're using aren't causing side effects. So again, just looking at a picture of the brain, the frontal lobe is this green part of the brain, which is the front part up towards the front, and it's actually the largest lobe of the brain. And it controls a lot of the parts of our brain that make our personality and our cognitive abilities, all those executive functions. So, you know, how we think and reason and inhibit some of our behavior, or even, you know, coordinating in our movements and our other thoughts and things like that. And so, as we said, if there are seizures that are involving different areas of the brain, it can cause changes in those neuronal networks. It can cause changes in how the neurons are connected to each other. And if we're altering those, that can sometimes cause the parts of the brain that are being altered to not work the way that they had in the past. So that can cause problems with reasoning, planning, impulse control, multitasking, sometimes even changes in personality. So again, it's very important for us to be recognizing and addressing these things if they're happening. So one important thing as far as, well, what can we do to fix it, is talk with your doctor, talk to your neurologist, talk to your epileptologist. And they would really need to kind of focus the right options or the right treatments on your individual circumstances or your individual cases. You know, we may want to look for other causes. You know, are there other medical problems that could be contributing to this? Either other, you know, problems like vitamin B12 deficiency, or if your thyroid is off, or things like that. Sometimes we may use compensatory strategies. So that's using things like our external brains or cell phones to keep lists and keep calendars. You know, the Epilepsy Foundation also has some great resources with seizure diaries and things like that to try to help keep track of things that maybe people may have more difficulty remembering. So using lists and notes and things to help keep track so that you're able to, even if you can't remember it, you know where to reference the information. Again, we may need to adjust those seizure medicines. So some medicines may worsen mood trouble, but it's also important to know that some medicines may improve mood. It's not absolute for every individual is different. Some people may have problems with one medicine but be okay with another, but that's why it's important to talk with your doctor, because we may need to change from one medicine to another to try to improve their mood. Sometimes we may recommend that we use medicines like antidepressants or other medicines like it to try to help improve the mood. And that kind of focuses on trying to correct that imbalance of the neurotransmitters. Maybe we need to try to boost the serotonin or try to boost the norepinephrine to try to help improve their mood. I've gotten this question quite a bit because I know, you know, a lot of the medicines that we use, the antidepressant medications like the SSRIs and SNRIs, when I've had patients where they look up the potential side effects and they look and they see on the list that seizures is on that list for potential side effects. And there's some good studies that have concluded that for the most part, those medicines don't increase the risk of having seizures. And even though there may be a potential, that potential is pretty darn small. And most people with epilepsy are able to use these medicines to help with their mood without any problems. One specific one that we often mention is bupropion. And that medicine has been shown to exacerbate seizures, especially at high doses. But even now, there's some more recent studies that have been coming out that if it's used at reasonable doses, especially for people who may have failed those other medicines, the SSRIs and SNRIs, Wellbutrin might be the right answer for them. And that may be something that they need. And it's not as clear as just saying, oh, well, this increases the potential risk, so we're not allowed to use it. You really need to talk with your doctor as far as what are the potential risks and what are the potential benefits. Because I certainly do have some patients who are able to still use medicines, even bupropion, which is one that, you know, if you would have asked me 5-6 years ago, maybe we would have said, oh, we don't want to use that. We can. So it's important to talk with your doctor. And then also, sometimes medicines are the right answer, but sometimes the right answer is seeing a psychologist or a psychiatrist. You know, a psychologist is a doctor who's trained to treat different mental health disorders, and they don't use medicines, they use different types of therapy. And sometimes those therapies can be just as effective as medicines. And the nice thing is, then you don't have to be on another medicine. And whether or not the treatment is best to do medicines, or it's better to do talk therapy and different types of therapy with a psychologist, which one may be best for you or for your loved one may be different. So for some people, maybe starting with the psychologist is best. For other people, maybe starting with the medicine is best. But no matter where you start, if things aren't fixed, being open to the other. So if you've started with medicines, being open to seeing a psychologist or vice versa, because sometimes the two together can work even better. So it's really important to be open and talk with your doctors as far as the appropriate treatments for those mood changes or behavior changes, because again, we want to make things better. We're treating the patient as the whole package, not just the seizures. So another very common disorder in people who have epilepsy is migraines. So as you can see from some of the statistics here, people who have migraines, people who have epilepsy may be much more likely to have migraines, or it's more common compared to people who don't have epilepsy. And again, that may be from multiple different factors, either genetic factors, maybe the cause of the seizures themselves, or again, some alterations in those neurotransmitters may play a role also. There are some seizure medicines that can help both seizures and migraines. So I named a few here, and the nice thing about that is anytime when we can use one medicine to fix or help two problems, get two birds with one stone, is always a good day. So we want to try to use these medicines not just to treat the seizures, but see if we can get double duty out of them and help with other problems as well. And I would say that goes similarly with those medicines that can help with mood trouble. So we may use them to help with their mood and with their seizures and get kind of double duty out of that same medicine. Another big thing that we like to talk with our patients about is sleep. As a lot of people know, sleep deprivation is a very common trigger for seizures. And we caution our young moms about that if they have a new baby at home, they need to be making sure they're getting enough sleep, because that can trigger seizures and make seizures more likely. And there are some sleep disorders that can affect epilepsy. A common one of the most common sleep disorders is obstructive sleep apnea. And that's a problem where we won't go into it too much, but essentially there's trouble where people have abnormal breathing and their airway kind of gets blocked off, it gets obstructed, and they stop breathing for a brief period of time, and their brain wakes up. It may not wake up fully to wakefulness, but it wakes up enough that they don't get normal restful sleep. So they don't get to cycle through all the normal stages of sleep. They stay in shallower sleep, which isn't as restful. And getting that obstructive sleep apnea under control by using things like a CPAP, which is the main treatment for one of the main treatments for that, can sometimes even help seizure frequency. It can help get seizures under control. So we want to screen for this, and certainly if people are having excessive sleepiness or having trouble sleeping, we want to try to address that, because if we can fix their sleep, we may be able to make their seizures better. And then I just mentioned some good things for sleep hygiene. Sometimes there may be a disorder, or it may just be bad habits. So making sure you have a regular sleep schedule, which means going to bed at the same time every night and trying to wake up at the same time every day, and giving yourself about an 8-hour window of sleep. They say we're creatures of habit. Our brain is a creature of habit. It likes to have the same pattern. So that's why people like me, unfortunately, wake up before our alarm sometimes, because our brain is used to this, and we have this habit. It's good to avoid taking naps during the day. We want to try to consolidate that sleep, to get all that sleep at night in one chunk. We want to try to avoid drinking caffeine in the afternoon time, because caffeine's in your system for a long time. And if you're drinking it in the afternoon, or especially in the evening, it could make it a lot harder for you to fall asleep at night, because it's still in your system. And then also another big thing is screens or lights when you're trying to lay down and sleep. Watching TV, or nowadays if you're on your cell phone at night, the light from those devices actually sends activating chemicals through your brain that tell you it's time to be awake. It makes it harder for you to fall asleep. So trying to do things just behaviorally that can promote your sleep can be really helpful. Now, I hesitated to mention pregnancy only because this really could be 1 or 2 full lectures. So I boiled it down to 3 slides, which is absolutely not adequate at all for pregnancy issues. But I just wanted to make a few key points. And again, it's very important to talk with your doctor if you or your loved one is pregnant, thinking about getting pregnant, or anything like that, because there's a lot of things that we want to think about. One important thing with pregnancy too is with contraception. So if women are not wanting to get pregnant and they're using methods to avoid pregnancy, it's important to know that some medications could make oral birth controls less effective, especially if they're used at higher doses. So it's important to check with your doctor if that may be the case. And that's usually more so with some of the older medications that are what we call enzyme-inducing medications, meaning that they cause you to metabolize things more quickly, like carbamazepine or phenytoin or phenobarbital, but can happen sometimes with topiramate at higher doses and things like that. It's always important to know that some contraceptives may also, especially if they have higher amounts of estrogen, could make your seizure medicines less effective by changing some of the levels of those medicines. So, getting your neurologist's input, obviously, I always say that the decision of what type of birth control a woman may choose is always kind of up to her and her OBGYN, but we like to at least give our 2 cents to be able to let folks know some things to think about, and avoiding birth control methods that may have higher amounts of estrogen can be really important. Also, when women are pregnant, we think about what are the risks of these medicines. So some medications may have an increased risk of birth defects, but it's important to note this second line here that other medications may not have any associated risk of birth defects. So in general, it's always very important to talk to your doctor about your specific situation and which medicines you're on to know what the potential risks are. Some medicines like lamotrigine and levetiracetam are not associated with an increased risk of birth defects. So we tend to prefer to use those in young women, whereas some other medicines we may try not to use if we don't have to. Obviously, if you are thinking about getting pregnant, planning ahead is always important, not just if you have epilepsy, but in general. We typically recommend that any woman who is of potential to get pregnant should take folic acid every day, typically at least 1 milligram of folic acid, just in case they would unexpectedly get pregnant. That way that folic acid is already in their system to help reduce the risk of birth defects. We want to try to optimize their medicines. So we want women to be on the least amount of medicine necessary to get the job done while they're pregnant. We don't want to add any extra because we don't want to add extra risk. And obviously, it's important to get good prenatal care and follow with an OBGYN before you get pregnant to try to make sure we're optimizing everything we do. And I can't stress this enough. This is incredibly important to remember that a vast majority of women with epilepsy who are still taking their seizure medicines still have normal, healthy babies. Fortunately, nowadays, we don't see it as often, but in the past, we would have some OBGYNs who would say to their patients that if they were taking seizure medicines and they got pregnant, they had to stop their seizure medicines. And we very strongly recommend not to do that. We want our women who are taking seizure medicines to not stop them abruptly, because that could cause their seizures to come back, which could also be dangerous for the baby. So even on those medicines, even some of the riskier ones, still a vast majority of women still have normal, healthy babies. So keep your epileptologist, your neurologist in the loop. This is a very important job for the epileptologist to help manage. And we always follow these women much more closely, even during their pregnancy. And one of the things that we follow more closely is their medication levels. So we may need to check blood work more frequent while they're pregnant, because during pregnancy, their levels may fall. And we need to keep a close eye to make sure that we're maintaining the same level so that they don't have breakthrough seizures. Again, the main goal is to avoid seizures as much as we can through those months of pregnancy. And that's what would fit in my nutshell, or at least the 3 slides. So again, this is a whole nother topic. This could be another hour or 2 or a whole conference. So talk with your doctor for more information about this. And just a few more slides. Again, we talked already about this, that we want to minimize the risk with medicines. So we need to think about how our medicines may interact with other medicines, or if they have long-term issues or side effects. We need to be thinking about, do those medicines cause changes with the liver or the kidneys? And we may need to adjust the dose if the medicines are cleared through the liver or the kidneys. Some of the newer medicines, we may not need to worry about this so much because they may not have risks to the liver or the kidneys. But again, it's important to talk with your doctor because we may need to monitor some blood work. We may need to look at that function or look at other electrolyte levels or vitamin D levels, which we'll talk about on the next slide. And again, their medications may interact with other medicines, similar to birth control pills, anticoagulants, and some other antibiotics, other medicines like that may be affected by your seizure medicines or may affect your seizure medications too. So again, it's important to talk with your doctor. And the last thing that I want to talk about is bone density. So this is something that's very important for folks, especially as they get older. Some medications may change how your body metabolizes vitamin D. And vitamin D is a hormone that your body makes that is really important for your bone health. And if it's low for a long time, your bones could get weaker and people could be at high risk of having fractures. So we may need to monitor their vitamin D closely depending on what medicines they're on. And we may need to do maybe even bone density tests if they're on medicines that could affect this in the long run. So to help with bone density, obviously talk with your doctor if your medicines may be contributing, but eating healthy and exercising. Exercise is a great thing to help build bone density just in general. Using your bones helps strengthen them. So that's a very important thing anybody can do to help with that. So lastly, kind of summing up a lot of this is, we really want to make sure that we're focusing on all these things. Often a lot of times when we're talking to people, we talk about their seizures, but people who have epilepsy, we need to treat more than just their seizures. We need to pay attention to the whole package, everything that's going on, because we want to make the person better as a whole, not just fix one problem or one aspect. So treating people with epilepsy is more than just treating their seizures. And we want to make sure that everybody's aware of that so that we can try to help. So that's the end of my lecture. I hope that was helpful. I tried to not speed through it too much, but certainly if there's questions, let me know.
Thank you very much, Dr. Kohler. That was very useful information. Really enjoyed that. Before we have any questions, I just launched a poll for the evaluations for each speaker. If you could fill that out, that would be great. It helps us with future programs. We really enjoy the feedback that we get. Let's see. Well, this is a question, I don't know if you feel comfortable answering this. It's pediatric neurology.
Okay.
Would you prescribe melatonin long-term in children with epilepsy?
So melatonin in general, even in children, so melatonin it's the same hormone that is secreted by the pineal gland, which is a gland in your brain that tells you that it's time to go to sleep. So melatonin, by taking extra amounts of it, really kind of helps boost the amount in your brain to try to help promote going to sleep. So there's little risk with continuing melatonin long term. Certainly we don't try to just add more and more and more melatonin, because at some point you kind of would max it out. But it certainly is okay to use even in children, because again, that's just the same hormone that your brain already makes.
Okay. There always seems to be talk about bone density for women. Do you need to know, what do you need to know for bone density in men?
So you're right. We think about it a lot more in women, because even in women who don't have epilepsy, as they may go through menopause and have changes in their hormones, that can sometimes make them be at a higher risk of developing low bone density. Men don't go through menopause, so they still have that testosterone, so the bone density is typically not affected as much. But again, for people who have epilepsy, whether you're a man or a woman, if you're on medicines that increase the metabolism of vitamin D and your vitamin D is low enough, that could cause your bone density to get lower regardless of whether you're a man or a woman. So it's important to talk with your doctor to check if you are on one of those medicines and maybe supplement your B12 or your vitamin D if necessary.
All right. I just want to point out that every other year, the Epilepsy Foundation, EFEPA, we do we host a Women in Epilepsy conference every year where we get into all that kind of stuff pretty intensely. So I just wanted to point that out.
And one thing I wanted to point out too, I may not have said this on my slides, I meant to, was, obviously the Epilepsy Foundation is a huge resource with a lot of these things. Things like the social stigma with epilepsy, just awareness of epilepsy. A lot of people think that they may be alone or that they're isolated, which is not the case, because there are so many people with epilepsy. There is a large community, and being aware of that. And that's one of the best things with the Epilepsy Foundation, is educating people about these things, and having events like this where people can be aware and get more information can go a long way with treating some of these other problems.
Excellent. Is there a pediatric epileptologist in the Valley? I think there are. Maybe there are. I think there's one at St. Luke's and a couple at Lehigh Valley Health Network, I believe.
Yeah, so we have 2 pediatric neurologists who treat epilepsy at St. Luke's, and I'm quite certain there are some at Lehigh Valley as well.
Right. There were some other questions. Oh, wait, can motor control, what? I'm not quite understanding that. Can persons with epilepsy have varied presentations of comorbidities throughout their lifetime? For example, can a child present with behavior or cognitive issues as a child, and then that diminishes over time, or can these issues come back later, and how that relates to epilepsy?
Yeah, so that they certainly can change over time. So sometimes when people first develop epilepsy, again, it all depends on what the cause is. If for people who may have developmental problems or injuries to the brain early in life, that could cause them to have some more difficulties. But as their brain matures and grows, they may be able to mature out of some of that. Some of it, if they may have more long-standing epilepsy, again, people may notice over time, if they have uncontrolled seizures, that their memory may gradually get a little bit different or altered over time. So these things absolutely do change over time. And that's why, when we're screening people, we don't just screen them the first time we see them. We screen them multiple times throughout the time that we're caring for them, because you're absolutely right. Things may change. It may be different from when they first develop epilepsy compared to years later.
I don't want to tread into different waters, but someone asked about CBD and the effect.
That's probably, at least for myself, I know I have a very long spiel, and that's probably more than we have time to talk about. CBD, I would say the very short version is, it's not one of our go-to first lines for a lot of these things, including seizures, partly because it's newer, there's less data, less information, and 2, the products, we have to be careful about the products we're talking about, whether it's medical marijuana or medications that are CBD or other cannabinoids. So that is a little bit longer of a topic, unfortunately.
That could be our next conference, right?
I think you talked about that last year, I believe, at the epilepsy conference, or the year
Yes,
before.
I believe so.
Yeah.
I get the impression more and more information is coming in on that subject.
I think there's always more information going on. I think I don't know if there's been any more breakthrough studies of late since the conference last year, but there's always more information with everything. There's always more information every day. So.
Is there genetic testing to help with determining different types of epilepsy or rare forms?
There are some genetic tests, yes. Again, that probably by itself could be its own complex lecture, but especially with some of the more severe epilepsies where people may have impaired cognition or things like that. Sometimes less severe epilepsies as well, that maybe don't affect people's ability to care for themselves also. But, and those can be helpful in some situations to help figure things out, especially in people who may have like Lennox-Gastaut syndrome or Dravet syndrome. Sometimes those genetic tests can maybe guide us a little bit towards one treatment or another, like there's one called GLUT1 deficiency. So there's a bunch of different things that can help.
And I think this is going to be the last question. Is it rare for someone at the age of 80 to start having seizures, and is there a cause at this age?
So it's not uncommon. So I don't have a slide handy, but when we think about the incidence of epilepsy, meaning at what age do people get it, it's what we call bimodal, meaning that if we're looking at age as our x-axis and when they develop epilepsy, there's a big peak in childhood. So we often see people or children, that may be a high time when people may develop epilepsy. But then it maybe gets less common in the middle-aged years, but it can still happen. So we have people in their 30s, 40s, 50s who develop epilepsy at that age. But then there's another big peak, kind of the wide bimodal. So there's a peak in the younger age, but then another peak as folks get older, kind of above like 60 or 70. And the causes for people who are younger and kids, they tend to be more presenting with their genetic abnormalities or injuries that they may have had very early on. As opposed to for older folks, people who may be 70 or 80, at that age, we wouldn't expect that we would be seeing their genetic problems manifesting for the first time. Those people may be from other things like in older people, more common causes may be things like strokes or tumors or other injuries to the brain, or if the brain is degenerating like from dementia or something like that. Or again, we may not be able to find the cause because it may not be any of those. But usually that would be kind of the breakdown depending on the age.
Okay, well, big thank you to you, Dr. Kohler, and our other speakers for coming out tonight and speaking. We had a really nice turnout of people. I'm really happy that we could connect in these times. And, for the panelists, keep in touch. For the people attending tonight, keep in touch. Give me a call. Give us a call if there's anything we can do to help you at this time. If I could just ask you to complete the poll before you leave this evening, that would be appreciative. So thank you very much this evening. Take care.